Hey, everybody. Turn this down just a little bit. This is Mr. Sam Cooke that you're listening to. Change is going to come. Dr. Wenzel asked us to play this. As you're entering the room, I'm just going to yak at you, see y'all coming in. If you've been with us before, you probably know this, but I'll just say it again. We're going to gather as a community for the next hour. We're going to ask questions of Dr. Wenzel, and he's going to share with us what he knows, the latest about the COVID-19 pandemic that's been tearing across the globe. We are going to go into the Q&A chat box. So if you take your finger, your cursor, whatever you got to manipulate your computer, go down into the chat box as that little thought bubble, right? Make sure, if you would, please make sure it's set to all panelists and attendees so you're talking to everybody. And then go ahead, as I'm about to do, and just type your name in. Hi, it's Sean. Add where you're from, where you're coming in from. And then we've been doing this thing, which I think is helpful. Hey, Catherine from Toronto. Catherine, would you do this for me? 2-word check-in. This is something that Professor Brené Brown at the University of Houston has been doing, and we've been sort of borrowing from that. And it's this idea of just 2 words. How you doing right now in 2 words? If you'll add your name in and the 2-word check-in. Our hope is vigilant and optimistic. Good way to be. It's been a tough couple of months, I know, or 3 months now, and going on however many more. We're going to learn about that in a minute. Ryan, how are you? Tired but fired up. Yeah, these polarities, right? It's really strange to be there. John, how are you? I believe it's John Wenzel, so I have a feeling, Dr. Wenzel, that may be a relation of yours. Mark,
it is
and anticipating. Yeah, it's interesting to see all of us reflecting back. What are the words that are sort of going through your minds and making sense of those emotions? You have so many of them. And it's okay to have those emotions. I mean, I'm no psychologist, but it's okay to be having lots of, maybe sometimes conflicting emotions right now. This is something none of us has experienced in our lifetimes. But we have the good fortune of someone who has seen pandemics before, and he's going to join us in just a quick minute. So let's continue. Jennifer, great to see you, my friend. Thirsty and curious. It's probably hot out. Yeah, in Washington, D.C., summer has broken out. It is today here 90-something and humid as hell. So I'm happy to be indoors for the next little while. Continue to add your names in here. Let's talk to each other as this program's going along. But if you would, my colleague Tristan Mohabir is running the deck. If you bring that forward. And then our colleagues Carrie Pine and Kareem Alston are making notes. So we'll have that for you a little bit later. Our colleague Yav Sarah Ferris is on Twitter. So if you want to make notes on Twitter or check in with others there, the hashtag we're organizing ourselves around is ComNetLive, ComNetlive. We turned down Mr. Cooke, but would encourage you, if you're looking for something to listen to during dinner time tonight, change is going to come. Sam Cooke, well worth your time. You can find it on Spotify, or even better, go buy it. Tony, how are you coming in? Interested to learn more? You're coming in from Bellevue, Washington. Well, welcome. We're happy to have you. The slide you're seeing in front of you is ComNetwork Local. And Tony, maybe you know this. In Seattle, and 16 other cities around the country: Detroit, Austin, Atlanta, Washington, D.C., New York, oh goodness, where else? Chicago, Miami, gonna run out of names, Dallas. There are these ComNetwork local groups that are building community in the places where you may be living and where you work. And so the idea is to connect you to other people who are doing communications for good work at foundations and nonprofits and social sector focused consultancy. So go on comnetwork.org and you can find links to the locals, and I think Carrie just put that into the chat for all of you. Jesper, nice to see you, tired and hopeful. Tristan, if you'll take the slide forward, sir. It's the other thing that we want to tell you about, and that is perhaps a little prescient, but certainly mindful. This has always been an issue over the last 401 years in our country's history. Racism, it's a conversation that many of us are having around the country right now. We're confronting some issues that perhaps we'd long known about, but hadn't perhaps put focused attention on until just now. I'll give you a little bit of a highlight. The network did a survey of everyone in our field just a couple of months ago now, about 6 weeks back, and we'll be sharing that in the Chronicle of Philanthropy shortly. One of the things I found most interesting was that before the murder of George Floyd in Minneapolis by the Minneapolis Police Department, before that murder occurred and the subsequent protests that we've seen in demonstrations, peaceful demonstrations we've seen around the country, 67% of the people who responded to our survey reported that they believed that there was going to be a significant change in racial equity narratives, or the narrative surrounding racial equity in America as a result of this pandemic. So in many ways, I think our field had a sense of some of the things that are erupting around the country now, even before they occurred, because of some of the inequities that we know have been occurring during the course of this pandemic and that Dr. Wenzel has been speaking about over the last many weeks that he has been with us. So this, by the way, just so I can talk directly to the slide, this is the journal Change Agent. Our colleague Tristan Mahabir made this with Michelle Norris, the former anchor of NPR's All Things Considered and the creator of the Race Card Project. Would encourage you to go find that. We've just put the link in, so welcome you to avail yourselves of that. There's a number of really interesting articles. Darren Walker is part of it, LeJean Montgomery Tabron from Kellogg Foundation is part of it. Really wonderful research. Also some real world case studies of how different organizations around the country, Jennifer Oldham, who's with us, is one of those folks who contributed, are doing this kind of work on racial equity and have been for some time. There's lots more work to be done, but would encourage you, please check that out. Avail yourselves of that. With that, I'm going to stop chatting because I think we're all now in the room. Dr. Wenzel is back with us for the 7th time, just to give you some sense of how much of a commitment and generosity and kindness he's been offering to all of us. Sir, thank you again for being with us. Look forward to hearing what you have to say. And
Thanks,
again,
John.
keep talking to each other in the chat.
So the first slide is obviously a title slide, but I included to show my email in case there are questions that come up later that you didn't want to ask in a group or couldn't get to. Secondly, remind me to tell you that I will mention the names of some drugs and some vaccines, but I have no equity in any company that does something for health, including products. And then thirdly, to thank you for tuning into the webinar. So next slide. So this is a picture of, let me get this out of the way here, Albert Camus, who is the author of The Plague. And he said, sometimes carrying on, just carrying on is a superhuman achievement. And I think that's really important as we look ahead. And particularly if you just look at the next slide, Kirsten. And the reason that we need to carry on, this is the global number of cases and a linear scale going from 0 up to 8 million on the vertical axis. And then time, if you will, left to right from January to June of 2008. So we're over 7 million cases globally, and you don't see any dip in this curve. This is still going on. We still need to carry on, as Camus would say, and be vigilant. Next slide. So if you look at the countries with the most new cases in the last 7 days, one of the things you've been looking at, if you look upper left, Brazil is now #1 with 174,000 cases within the last week, even more than the United States, which is 158,000. And then to the right, India, another country where poor people are disproportionately being hurt by this pandemic. The Russian Federation, and then Peru and Chile with 36,000 and 34,000. So the countries certainly around the globe, but including India, Russia, and South American countries are really contributing to the new cases, even though our own numbers are beginning to flatten a little bit. Next slide. So what this shows you the leading causes of death globally. And you see up top, COVID-19 wasn't even on the graph 3 months ago. It's now surpassed malaria as the #1 causes of death globally. So again, this hasn't gone away. It's here. We're part of the globe, and we have a huge proportion of susceptible people in the next 6 months or more. Next slide. So if you look at the United States, and what you'll see is that we have 19 states with rising number of cases. And if you just look at some of the ones on the top, for example, California, and then Texas, and now we'll move over to Florida, but North Carolina and then South Carolina further to the right, with showing no real dips, and then but a straight line up. Utah at the bottom, and then some states where the rates have gone down and then appear to be going up again. And I want to point out that so far, we have 1,000 or 100,000, 1 million rather than 973,000. So almost 2 million cases and over 110,000 deaths. And just to remind you where we were not long ago, April 1st, 200,000 cases. Now we're at 2 million in just 3 months, 10 times the number of cases. The number of deaths on April 1st, 2,000. Now we're over 50 times the number of deaths. So this hasn't gone away, even though we're a little flattened in the United States. Next slide. So one of the points I want to bring up is that more and more evidence suggests that SARS-CoV-2, the cause of COVID-19, isn't just a pulmonary disease. It's actually, more importantly, in the late stages, a systemic vascular disease. And if you look at the bullets on the left, all blood vessels have an endothelial cell interlying with the ACE2 receptors, which is the docking site for the knob that sticks off the coronavirus. They all have this receptor. And if you look to the right at the diagram, the cartoon here of the lumen of a blood vessel, and see pointed out the thin layer, a single layer of endothelial cells with enormous responsibility, if you will. They regulate blood pressure, they prevent inflammation, they inhibit clotting, and they're the gatekeeper for molecules and immune cells going in and out. So they have huge responsibilities because we don't want unusual inflammation that'll obstruct the pathway. And we don't want clotting either. But in fact, that's exactly what we're seeing when the immune system goes awry with COVID late in disease. Now, if you look at the second bullet on the left, COVID-19, as you know, can present with heart attacks in 50-year-olds. We've seen strokes in 45-year-olds, kidney failure, all related to clots and inflamed blood vessels in different parts of the body. And the SARS-2 attaches to the ACE2 receptor whenever it gets into the bloodstream, and it can then cause damage to that organ. The destruction of the cells, now we're talking about the endothelial cells when destroyed, cause inflammation, which clogs up the lumen, vascular leaking, clotting, obstruction of blood, and then ends with its own signals for a systematic cytokine storm throughout the body that's often related to the cause of death. A new study that I just cited at the bottom on the left, the autopsy of lungs of patients with COVID-19 had 9 times the capillary clots as seen with people who died of severe H1N1 in 2009 and 10. So this is quite serious. Next slide. Now, recently, there's still a spate of articles saying that COVID is not much more than the influenza. And I want to disabuse you of that thought with data from CDC. If you look at influenza compared to COVID, the number of deaths. So in the last 10 years, when CDC has actually used the same counting system, we've had as low as 12,000 deaths in 1 year to 61,000 in another year in the last decade. So far, in about 3 months, we've had now the number over 110,000 deaths due to COVID-19. The mortality in seasonal flu is about 0.1%, 1 in 1,000, and it's 3 to 5 times that in COVID-19. Of all the people with seasonal flu, as many as 1 to 2% get hospitalized for a mean stay of 5 to 6 days. But if you look to the right with COVID, about 20% are hospitalized for a mean stay of 11 days. The R0, the number of secondary cases for each primary, is about 1.3 for seasonal flu and 2 to 3 for COVID. And what makes it difficult for control is that in terms of contagious periods, influenza mostly contagious in the first 4 to 5 days after symptoms. The problem with COVID, people are contagious for several days before symptoms. So this is a big deal, and COVID is much worse. Next slide. One of the arguments that people have used who've been talking about COVID as just the flu is to say, well, you know what, even social distancing didn't work. But most of them stopped the curve at the peak of flu. So if you look at the yellow, that's influenza A this year, and the green influenza B, and you look at the peak in February and early March, That's when the people who think that the social distancing didn't help that much ended their curve. But as you can just follow the curve to the right, you can see the dramatic fall linked to social distancing that we did for COVID actually shut down influenza. Next slide. So it turns out that if you look at clusters, the super transmitters are quite important. And in a study that came out of Hong Kong, if that the 20% of the COVID cases accounted for 80% of the subsequent transmission, sort of the 20-80 rule, if you will. And what the investigators did, if you look at the first bullet, is look at clusters in Hong Kong, and they did very robust contact tracing and found 1,037 confirmed cases. And then if they look at super spreading threshold of, let's say, 6 to 8 cases, they identified 5 to 7 likely cluster events, significantly more common in social exposures than family exposures. And this suggests that rapid tracing and quarantine of contacts was a critical piece in pandemic control, along with social distancing. And it turns out, surprisingly, 70% of infected people transmit no virus. So what makes a person be able to transmit it, or even makes them a super spreader, is unclear. But nevertheless, although we're all equal opportunities recipients of the virus, it appears, there are not equal opportunities for those who transmit it. Next slide. And just to give you an example of the transmission routes, so the B on the left diagram shows you one person who entered a bar listening to the band music, and all of these contacts, well over 100, resulted from that single super spreader who was very active, obviously, in getting around, and perhaps was a super spreader because he generated aerosols of droplets, not just large droplets. If you look at the W at the top in the middle, that means at work. Again, a single person was able to transmit this. You can see about 20 people. And underneath the T for temple, again, a single super spreader, all of those subsequent infections. So again, a single super spreader can account for a huge proportion, 80% in this study, of secondary transmissions. Next slide. So it turns out in a Chinese study and a Japanese study, to kind of build on what we know about who's spreading this, indoor transmission of SARS-CoV-2 is really important. In the Chinese study, there were 318 clusters or outbreaks involving 3 or more people. 1,245 were confirmed cases, and all 100% occurred indoors. And then when they looked at the source, what they found was that 80% of the infections occurred at home in this Chinese study. I'll come back to why that might have been. 34% in transportation, meaning public transit, and surprisingly 4% and 2% in restaurant and entertainment. However, this study is confounded by the fact that China went in, closed a lot of restaurants and bars. So the low numbers may be that they didn't have access to that. But public transport is what I would take out of this. There obviously overlaps, people who are both home and transport. And the average number of secondary cases, you can see, varied between 3.6 and 4.9. In a separate Japanese study, there were 110 cases, 1 or more, 25% of which generated secondary cases. So it's not dissimilar from the 20% in the earlier slide. Turns out there are 19-fold greater odds of transmission in a closed environment than outdoors. And the odds ratio of transmitting 3 or more, that is clustered, if you were indoors compared to outdoors, 32.6, which actually goes back to the similar slide I showed you about super spreaders. Next slide. Good news about being outdoors in the summer. Next slide. So what I have on this slide, the title is COVID-19 Pandemic Meets Moral Outrage. And Clearly, we know some things. We know that social distancing worked for the public's health, without question. And obviously hand washing and masks. And yet massive protests address a compelling moral issue, no question. However, it's one that challenges public health because the virus ignores morality. And one of my criticisms of CDC is the failure to articulate the competing issues, which I think may undermine their future efforts. For example, for months, public health authorities said, we don't want your small business to open up because the crowds may lead to a problem of public health and transmission of this virus. We don't want you to attend the Hasidic funeral of a respected elder because, again, crowding may lead to a public health issue, and similarly to churchgoers and so forth. And yet, what they'll say is, but this is different. And it is different from both an ethical issue and a societal issue. But what isn't different is the behavior of the virus in crowds. So that's what we have to keep in mind when we look at the mixture, if you will, the pandemic and the moral outrage. Next slide. So if I look at mass gatherings in the era of COVID-19 and look at first the social demonstrations, or we may see in the future religious or sporting events in congregations, the risks are clear. There's little social distancing in the protests, and people yelling may actually contribute to increasing transmission from more droplets and more small droplets. And it may be worse if mucous membranes are damaged by tear gas. And the confinement, if you have bad luck and wind up in a patrol wagon or a crowded jail, would actually make things worse. So what I would recommend for the protesters is wear a mask. Keep social distance from the non-mask wearers, if at all possible. And when I ask the law enforcement people, please practice restraint for your own health and the health of the protesters. The modulating factor, which you now have seen the data, is these are outdoors. And so the risk is considerably lower, not zero, but lower than indoors. A second sort of ethical issue is one for the protesters to say, I'm willing to take a small risk of myself of getting infected. But the second ethical issue is, what do protesters do after the end of the protest or during it even, when they contact high-risk individuals, their grandmother who's age 90, a friend who has diabetes and heart disease, a colleague who has a kidney transplant? I would hope that they would go into some kind of voluntary quarantine for the 2-week interval before they expose these very high-risk people, including their friends and relatives, to COVID. And that's not an issue that I think has been receiving enough attention. So then I tried to look up data on what do we know about risk of viral transmission in mass gatherings. There are very few data out there, most of them related to the Hajj, the annual trek to Mecca. Not quite analogous because this is a huge crowd, 2.4 million for 6 or 7 days. But what one team did is actually screen a large sample of the people before the Hajj and after, and ask what proportion were carrying either rhinovirus, seasonal coronavirus, or influenza. And before it was 7.4%, afterwards was 45.4% after the 1 week exposure to large crowds. So I'm not saying in this analogy will hold for the current protesters around the world, but that you can show that with crowding, enormous proportion of patients can get viral transmission. In fact, the good news is 50% reduction in influenza-like illness had the flu vaccine been given. So those people who had the flu vaccine before the Hajj did much better. And we ought to keep that in mind as we think about mass gatherings in the fall and the winter. Get the flu vaccine. Perhaps a little bit more relevant to this, at the bottom of the slide, if you can see it, is if you go back to 1918, and there were 2 cities, Philadelphia and Detroit, that allowed celebratory type of parades. And they were very influential in significant transmission of influenza of 1918-19, in contrast to St. Louis, that decided they were not going to hold any kind of parades, and they had much fewer transmissions. Next slide. So the two public health issues have also been colliding with respect to the fact that some people would list them both as public health issues. Racism on the one hand, and the COVID-19 pandemic as a public health issue. Tom Frieden, very recently, the former head of CDC, was asked about the protests, and he said the threat of protests is tiny compared to the threat created when governments lose community trust. While that may be true, what he did is actually something that that CDC has been doing, is comparing on the one hand the threat of a public health problem with the threat of community trust. He was quickly responded to that, and Jonah Goldberg, the conservative reporter, said the threat to public health trust goes up. In fact, Dr. Frieden, if the COVID persists or increases, and you've endorsed that perspective. We also know, the third bullet, that studies have shown up to 100,000 excess premature deaths in African Americans versus whites, thought to be related to both economic and healthcare disparity. And so that in itself is a public health threat. Police violence has been labeled a public health issue for some. On the other side, if we look at COVID-19 pandemic, new models that have come out, Fred Hutchinson, and endorsed by Dr. Lipsitz, who's a modeler at Harvard, each day of protest, each day, could lead to 3,000 new cases and up to 500 deaths, though they would be greatly reduced in states reigning in the pandemic. So that's good news for New York and New Jersey, where the rates are going down, but not so good for Utah or North Carolina or South Carolina, where the rates are clearly going up. And should there be new introductions, they could expand exponentially if not controlled as we open up our society. Tony Fauci very recently said, I get very concerned. There is a risk. I can say that with certainty. So how we balance this, how this will come out, it's still a lot of uncertainty, even though there's some risk for sure. Next slide. So genomic sequencing is essentially fingerprinting of individual viruses, and it's been very useful in COVID-19 tracking. If there's a history that outbreaks are shorter and smaller whenever we have any kind of genomic sequencing, or we actually have specific fingerprinting. So we know if there's a cluster, was it due to 3 or 4 introductions or a single one? The goal is to refine excellent contact tracing with fingerprinting of the virus, distinguishing new introduction versus a surge in the local transmission. To me, this will become even more important as global travel opens up and we begin to see hotspots. Is it due to the one person who came from Italy or the other who came from Portugal, or due to a US strain that just took over? Now, New Zealand, especially, and Australia got out with fingerprinting. New Zealand actually fingerprinted 25% of all their samples with a goal of doing 3 times that, 75%. The shortcomings, and by the way, New Zealand now reports no new cases. And what they've done is very aggressive fingerprinting and contact tracing. The shortcomings, it requires widespread testing and resources, and sure can miss people without symptoms. Next slide. So I want to show you the issue of Iceland. Really interesting study. And Iceland controlled COVID-19 without a lockdown, without any public discussion of masks. But look what they did. While we waited, in January, Iceland already had a response team assembled, led by scientists and medical experts. By February, prior to their first case, they already had a contact tracing team organized and in place. And when soon thereafter they had their first case, All 56 of the contacts were in isolation by midnight. They did respond with nightclub, high school, and colleges closed, and they limited gatherings to 20 and cut rare flights from the United States. Didn't all of them, but just a few of them. But they left the schools, high school, or rather the grade schools open, and many of the restaurants open. But with countrywide genealogy that they have had for years, called decode genetics, this is an unusual country where they actually have blood samples from 50% of the citizens that can contact anybody very quickly. They actually retrofitted that system, and where they did now actually is fingerprinting of all of their isolates. And by mid-May, they had 2 new cases in the prior week. So Iceland is beginning to open up with primarily a contact tracing program aided by fingerprinting. Next slide. More recently, economists in the United States and around the globe have actually suggested that maybe the blunt instrument was needed early, but we could have opened up some businesses if we were more targeted. And on the left side of the New York area, they looked at employment of each zip code, going from 0 employers to over 200,000. So the darker the shading, as you can see with Manhattan, the greater number of employees in each of the zip codes. On the right, however, they said look at the same zip codes, and they said, let's look where the COVID-19 infections are. And again, 0 to 4,400, the dark shades represent high clusters of infections. And what you see, perhaps surprising, is Manhattan isn't a hotbed of infections, but there are hotspots in the Queens and Brooklyn and other places around the city. And they're suggesting that maybe once we had a little better control of things, we might have been able to open up if we use certain parameters, which are shown in the next slide. So they're saying targeted closing of businesses may work if we saw that areas with high rates, and we could make policy depending on the rates, the testing available, the contact tracing had to be strong, and the capacity in the hospital is good. Measure the intensity of each contact for businesses by cell phone data, and ask the question, how much is indoors versus outdoors? So it sounds very logical. And I would look at South Korea, which did a lot of very aggressive contact tracing. Remember, their first case on January 21st was 1 day before ours, but they did aggressive contact tracing, and they had individual phone cell thing that probably wouldn't work in our society that values individual security. And what they found using their phone data and widespread testing and publishing even high-risk business, so they could tell you this Starbucks in the last 2 days had a lot of cases, other ones didn't. So the people themselves responded by not going to the one with cases. May 29th, per capita US mortality was 295 per million, was 60-fold greater than South Carolina. So their aggressive approach was actually useful. Recent models suggest, from the economists, economic costs could have been reduced by 1/3 if we had more nuanced policy. Again, you can't employ this when you're having a huge outbreak, as New York did early, but later on, maybe make some decisions. How well that would go over to say that this neighborhood's safe, another one isn't, I don't know. I think we'd run into some complications. Next slide. I want to show you in this slide the 2 efficacy clinical trials for Remdesivir, the only approved drug, and a 3rd dose comparison study. So the first 2 studies were efficacy clinical trials, both randomized, double-blind, placebo-controlled. Number 1 at the top was 10 hospitals in Hubei, China, 237 people, and studied 10 days therapy, and time to clinical improvement did not change, 21 days with Remdesivir, 2 shorter of 23 days with placebo. The mortality at day 28, again, 14% in Remdesivir, 13% placebo. This study published early in Lancet. A larger, almost 5 times that size, randomized study internationally had a number of 1,063 volunteers in the clinical trial. And in this study, the medical time to recovery with Remdesivir, 11 days versus placebo, 15 days. That 4-day difference was statistically significant. So it had an impact. Mortality at day 14, a trend was 7.1% for Remdesivir, 11.9% with placebo, was not significant. And then the third dose comparison was 5 days versus 10 days, looking at day 14 clinical improvement, no change, 64% with 5 days, 54% with 10 days. Suggestion that if you had limited drug, you could probably get away with 5 days, but we don't know that for sure because they didn't have a control group. Next slide. So if I were to summarize what we know about Remdesivir, it's the only drug that we know have had an effect so far on COVID-19. But that effect is a modest improvement, 4 days in clinical outcome. And the issue is we have no data that it saves lives. And so far, the FDA has approved it for emergency use for severe cases. And that's where we are with Remdesivir. Next slide. So 5 companies have been awarded $2.24 billion to help develop COVID-19 vaccines. These are listed. Moderna, AstraZeneca, combining their data with Oxford University studies, Johnson & Johnson, Merck, and Pfizer. And what we've learned is that if all 3 of them go to phase 3 trials, there'll be an estimated 30,000 volunteers in each, or 150,000 if all 5 go into stage 3 clinical trials. That'd be tremendous. 100 million doses are possible by winter because these companies have agreed to begin to create millions of doses of available vaccine and take a risk even before they know the phase 3 data. I show you the picture of Tony Fauci, who raises the uncertainties, even though he's optimistic. We have to know, will the vaccine be effective? And what will be the duration of immunity? Next slide. So I show you an updated slide from just a few days ago in Lancet. And I just wanted to have you look at the all the companies that they listed at vaccines in phases 1 or 2 of clinical trials. But I just want to show you in the middle the properties on the right-hand side of the vaccines. Many different types of vaccines. The messenger RNA vaccine, which is probably the most versatile, the most quickly able to actually come to phase 3 trials. And versatile because even if the virus changes in any way with the mutation, the platforms can adapt to that. There are DNA vaccines, live viruses that are harmless in people, programmed to make a critical protein of the COVID virus to which we would respond if we got that vaccine with antibodies that would stop the virus. Then there are killed vaccines, as we use some in our influenza vaccine. And then there's a protein subunit as we use in some flu vaccine. In this case, would be only this piece of the subunit for the protrusion, if you will, the knob, the spike on the COVID. And we would make antibodies to that and inhibit the vaccine. So a lot of clinical trials with different kinds of vaccine style. Next slide. So to recap what I've said about COVID-19, it's an ongoing pandemic. We have to keep worrying about this. The global rates are rising. And in the United States, even though our numbers are flattening, we're seeing increasing record cases in new cases in several of our states. Despite now knowing that COVID-19 is a life-threatening infection worse than influenza. Most transmissions, single and multiple, occur indoors. And that's great for us as we face the warm weather now. 20% of infected people transmit 80% of secondary cases, which is interesting and surprisingly and of interest. We don't know the reasons why 70% of infected people in some studies never transmit the coronavirus. We know social distancing works, masks work. We now have a perspective that COVID-19 is a vascular disease affecting the entire body. And we now have sufficient evidence in several countries, including our own, that efficient contact tracing is highly effective control measure. And lastly, it's got complicated. COVID-19 has met moral outrage in our protests. And I would say, related to that, but life is complicated. There are always combined threads of social, economic, ethical, and public health issues intertwined with any kind of large challenge for us. So as Americans, I think we have a goal of minimizing, if you will, the harm from COVID-19 while applauding all of those who want to express their appropriate support of very important and very delayed civic changes in our country. So what I would suggest is what we really need to do both is to be persistent, if you will, come to work every day, as Albert Camus would say, and really this is the superhuman task, is to stay focused and continue to invest in our protests as well as our control of COVID-19. I think we can probably do both. Thank you, Sean. I'd be ready to entertain some questions.
We have quite a few, so let's get to them. And everybody, if you'd like, I am looking in the Q&A box for your questions. So please do put them in there. It's just adjacent to the chat. Why don't we start with our friend Jennifer, who asks, are people with clotting disorders at a higher risk for death by COVID or for contracting the virus?
It's a great question, and we worry about that. Don't yet have solid data to know that that's a risk, but I would consider them somewhat on the high risk spectrum because of that. We're not sure what would happen with the immune response that could change the shift in balance between their anticoagulant that they're on, for example, because of some genetic change in the clotting system that has been identified for them. So we don't know for sure. I would be concerned about that.
Okay, and our friend Mohammed asks, is it possible that fewer cases of influenza happen because the resources directed to COVID-19, like swab and lab capacity? In other words, were we undercounting flu this year?
Well, the way that we count flu is different from the way that we count COVID, by the way. COVID, in order to be counted as a case, you have to have a confirmed case, usually the nucleic acid screen. What the CDC does to count flu is look at the excess number of deaths due to either flu or pneumonia. And then they model the data depending on who's been in the hospital, who's been in the clinic, how many positive tests, and that's how they come up with it. So it's, if anything, if we were to compare just those cases of influenza with confirmed culture or screening, we would probably have a much lower number than the 12,000 to 68,000. So it's possible that maybe we undercounted flu. Is that what the question is, I think? But I think the key point I would take away was, no matter what happened, this is a sustained drop of influenza coincident with social distancing and contact tracing. And even if you had a blip a little bit, you wouldn't see that sustained drop after the end of that. So I think it was really social distancing that had an effect on two viruses.
So a sort of a supplemental question to that, this is my own question, would be, if you fall ill with flu-like symptoms now, knowing that influenza has dropped significantly, should you consider getting a COVID test? Is it more likely that you've been exposed to COVID or influenza if you develop flu-like symptoms?
Yeah, there's no question. Yeah, absolutely. The answer is yes. In a COVID epidemic, even when there's flu, in a COVID epidemic, you're more likely to have COVID. Now with the absence of flu, surely there are other viruses out there, no question. And I would hope that you would have something else much more benign, a rhinovirus, some adenovirus, if you will. But the odds are that you probably are in a high prevalence area for having COVID.
Okay. Kelly, our friend, asks, and maybe you could repeat back some of what you were talking about with the example from the Hajj. She asks, do we need to wear masks if we're outside and we're not in a crowd? Are there any inherent health implications to wearing a mask?
None at all. So if you're out in a park, you're walking on a mountain trail, you're away more than 20 or 30 feet from other people, I don't think you need a mask at all. When people have talked about masks, by the way, with the crowding, go to another comment that people have been concerned about in the last few days. Again, remember what the mask does. It actually keeps the heat inside, because as you breathe, besides sweating on a hot day, your breathing actually helps your body to lower temperature. So one of the things about putting a mask on is there's a chance that you could have a temperature elevation. And if you're not drinking, get yourself in trouble, such as with heat exhaustion. So again, come back to, if you're out in the open or you're exercising outside, it's probably not a good idea to have a mask open, and you don't even need one if you're outside in the open.
Gotcha. But if you were to go out in, a couple of days, there's more than likely than not going to be more demonstrations occurring, the peaceful demonstrations we've seen around the country. If you want to participate in that, your recommendation would be, what should you bring with you if you're planning to go to a protest?
Absolutely. Great question. Thank you, Sean. Because I would want people to wear a mask. I would want them to bring a spare. I would want them to have access to water so that they don't get themselves dehydrated and elevated temperature possibility with a mask. If the mask gets soaked, that's the time to put on your spare, because it's really not going to function as one with integrity would have. So again, have that. If you have a mask on and you have symptoms, your heart is racing, you feel a little dizzy, take your mask off, get outside of the crowd, get into someplace cool, lower your temperature, maybe even call for help if you have any kind of dizziness or feel uncomfortable.
Our friend Katie asks, and a lot of people are interested in the answer to this question, thank you again for all the useful information and insight. The WHO has recently put out a lot of information that has been very confusing. On their website, they don't specifically recommend mask usage for the general public. Why is that?
I'm not sure what is happening with World Health, but I think they haven't been very clear. So first, let's talk about one of the things that they brought up was who's transmitting the virus, and it's a rare case if somebody doesn't if somebody has no symptoms. Just to put that first, of all the people who transmit, 45% roughly, these estimates vary, 45% of people who are preclinical. So they have no symptoms, but in 2 days or 5 days or 6 days, they will. So they have their preclinical and their transmission. Another 40% probably are people who have mild symptoms, don't recognize it as anything serious, trivialize it as nothing big. Or we all have a different perception of what we mean by when we're ill. And they may say, I just don't feel. So that's 85% of people. So that leaves us about 15%. And of that, 5 to 10 in each of two categories. The people who are asymptomatic, who never get symptoms, they're low. I don't know if I call it rare, but they're low. And then the people who pick up the virus from a contaminated surface, touch their eye or mucous membranes of their nose and mouth. So that's aside. Again, mask outside, I would say we have compelling data for a crowd that you can actually cut down your risk if you wear a mask and it is put on correctly and you don't mess with it. So I don't know where that part came from, other than maybe they were confusing people with little social contact with those who have much more.
Along those lines, just a clarifying question, how are we defining crowds? Because I think for some of us, we live in different areas, and a crowd for us might be, there's 10 people on the sidewalk. For others, we're seeing pictures, video from around the country of these mass demonstrations where there are hundreds, if not thousands of people around. So what, in your mind, when we're talking about crowds, how do we define that?
Well, what I would say is if you can stay 15 or 20 feet away from other people at all times, you're safe. And what I would say is you have those massive crowds or smaller crowds, the more people there are in we'll say an area, a fixed area, the more possibility for transmission to you or from you, we'll say. So there are two general thoughts. Again, what we're trying to do is if you're in a crowd, keep you from transmitting and hopefully keep you from inhaling or getting one of the droplets from somebody else who's mostly within 10 feet of you. 6 feet is the rough guideline the CDC uses, but we know too much more now. We know the droplets don't stop at 6 feet, and we know that droplet nuclei can hang in the area for hours. But when you're outside, again, it's probably close contact that counts even more than the aerosols. So again, it's a judgment call. If you can be, again, 15 feet away or so, you're really pretty safe outdoors.
Gotcha. So there's a little bit of relativism here. You're going out for that jog. You're on a path. There are other people out there. More often than not, you're alone. Probably okay. Maybe bring a mask, cover yourself as you're passing. But you're going out to a protest, for instance, much different kinds of protocols.
Absolutely. And if someone runs by you and it's 5 seconds of 4 feet contact, I think that's really low risk.
Okay. So folks, go out and get your exercise. Take deeper
definitely.
precautions.
Don't stop exercising.
Yeah. Okay. So our friend Julie asks, we know about 70% of infected people won't spread the disease, could make people feel more cavalier about the need for social distancing. How can we message this so it doesn't have a negative effect? So as we're learning more information, there's a temptation for us to start minimizing risk. How do we talk about this in a way that gets it clear in people's minds? There is still a very significant danger out there. Notwithstanding, people clearly, the statistics sometimes are a little bit anesthetizing. You hear 110,000 deaths, but if you don't know anybody, it doesn't feel real.
Well, I think what the data do is give you some comfort in knowing what some of the facts are better than you did before. But in fact, the way that I would interpret this is, again, focus on the outdoors versus the indoors. That's easy. The second is how many people are indoors, for example, and how close a contact you may have, for example. So I hope that people know that there's a little bit of probability in all of this. And if you're indoor, what you should be asking yourself is, am I in an area where there could be a super spreader? And it's not 1 in 5 people are super spreaders, but the super spreaders represent 1 in 5, if you will, of the transmitters, but 80% of the cases. So hopefully people won't distort the message to say, I might be lucky, but you would have to couch it in those terms because we really can't predict the super spreader from the non-super spreader or the spreader from the 70% of people who generally don't. So it's now test your risk tolerance. And I would be careful with that.
And just to reiterate, just to bring back risk tolerance, if you were out protesting within the last 7, 8, 10 days, 15 days, whatever it's been now, your recommendation is perhaps you quarantine, particularly being mindful of folks who may be at higher risk.
Yeah, I really think that's true. And if you stop protesting, you've done it for a week, or you're going to go back and do it in 2 or 3 weeks, remember that you could be a carrier before symptoms or had mild symptoms, and you could transmit it to somebody who's high risk for a terrible outcome. And I think there's an ethical and a public health reason for quarantining yourself for the longest incubation, 14 days, at least from those high risk people.
That actually gets us to our friend Jennifer's question. She had another, and it was this: why is 14 days the recommended quarantine time? She recently read about a person who said it took them 18 days for them to be completely symptom-free after being diagnosed positively. They got a positive diagnosis for COVID-19. Should symptom-free people with a positive result be retested after 14 days to determine whether they're still contagious?
And generally, probably not. Most people think that some people have said even 9 days after the onset of symptoms, most people will not have a virus that's transmissible. Others have said it looks closer to 14 days. So we're not talking about symptoms, which can last months, in fact. And that's one of the problems with this disease. The prolonged convalescent period can be horrible. And we're also, again, not testing, saying go get tested, because the RNA can persist for weeks after even the 2 weeks we're finding. So it turns out that Mr. Floyd, who was tested positive at the time of his postmortem examination, was also positive a month before, where he probably was really infectious and beginning his case. But even a month later, you can still have the RNA of the virus hanging out. So I don't think, and this should be of comfort to the police officers, maybe, strangely enough, I don't think he was able to transmit the virus, but I think he was a carrier of the nucleic acid weeks after the onset of his disease.
Okay, next question. We've got a few more. We'll try to get to as many of these as we can, gang. Kim asks, what do you think, this is another one about the WHO, what do you think about the WHO's comments this week about asymptomatic or pre-symptomatic individuals rarely transmitting the virus and then walking that back? So we're now many months into this, lots of information coming at us. I think you're a physician, you are used to, as new information is arriving, having a good sense of how one sorts that information and makes sense of it, makes meaning of it. For the rest of us, we're getting a crash course in Bio 405 when most of us didn't get out of AP biology.
Well, I think the World Health and CDC both need to be sure that they transmit the facts consistently and accurately. And it's not always simple. You need to be nuanced. And I used to criticize the CDC after their H1N1 communication. They didn't have what I would call the lexicon of uncertainty. There are things we don't know. And people can handle that as long as we tell them, this is what we know, this is what we don't know, here are our assumptions. So World Health made a kind of a cavalier statement, and they had to walk it back. And again, what I would have you remember is 45% of people pre-symptomatic, 40% of people who probably have mild symptoms transmit the virus, and we're down to about 15% people who never get symptoms or picked it up from the environment, touching surface. So hopefully what this doesn't do is discourage you from not listening to public health people. But I think the lesson should go back to World Health and CDC. We need you to be careful. We need you to be nuanced. We don't hold you in a negative way if you tell us what you don't know, but tell us what your assumptions are.
And just a sidebar to that, there's a fantastic article in the Atlantic magazine. Carrie, maybe you can find it and toss it into the chat, that made sort of an assessment of the communications work that CDC and WHO have been doing. And this was from a woman named, I believe it was Erin DiResta. If you Google that, Erin DiResta in the Atlantic. She's a researcher at Stanford University. And one of her big observations is not just some of the challenges that WHO and CDC have had in communicating, but even the platforms that they're using. Some folks have likened that to using horse and buggy communications at a time of an explosive constellation of we live in a totally different information ecosystem, and they have not necessarily figured out how to communicate in that new 21st century ecosystem. Yeah. Alexandra asks, this is a little technical, so I'll see if I can spit this out properly. Is there any relationship between RNA viral load versus viable virus or viral culture, considering infectivity for patients or healthcare workers with persistent prolonged PCR plus, I don't know what that means, more than 14 days?
Well, again, what I think is that you would worry more about a higher viral RNA in general. But what I haven't seen is really large studies that have taken patients, a large sample of patients, cultured them every other day for a month and said, this is how long the virus really lasts. But the RNA persisted all the way through. And by the way, there was more RNA on day 5 and 8 than day 14. That's the study that we need. We don't have that out there. It does make you a little more concerned that there's a higher RNA. But again, I think most people think that there's probably no transmissible virus after about 14 days.
Someone did put their name in. Anonymous question says, you've mentioned surgical masks are better than cotton in the past, but my best friend is layering her young daughter with an N95 mask inside of a homemade cotton mask. Is that layering necessary or effective, or would she be better off with just a surgical mask?
It's probably effective, but it's not necessary, and it sounds horribly uncomfortable. If you wear, as I did, particularly with H1N1 epidemic in 5 countries in Latin America in 2009, after a couple hours of wearing even an N95, uh, you just feel the heat all around you. You're dying to take it off to have a breath of cooler air and cool off yourself. So don't layer an N95 with anything else. And some of the double layers of cloth are, in fact, probably getting pretty close to good, protection, maybe not quite N95. And I think quite similar, if not equal to surgical masks these days.
And again, your recommendation might be if you're going to take those extra precautions, that maybe is more appropriate when you're inside in a place like a grocery store where you know you're going to be encountering lots of people versus maybe that walk on a path in the park.
Absolutely, absolutely. I think indoors is where we have to focus, look at the number of people, see what your risk tolerance is, but I would want protection from airborne particles.
Gotcha. Our friend Alice, a couple more questions. I'm going to try to get to all these if you're okay with that.
Sure.
Allison asks, there's still a lot of uncertainty about what schools should be doing this fall, especially for younger kids who don't know or can't wear masks for long periods of time. That's my little people. Do you have any advice, or have you seen any best practices emerging in other countries?
Well, it's important that, in some countries where they kept the schools open, in general, young people, don't get severe disease. And that's the most comforting part if you're talking about grade school or even high school. Colleges might be a little separate issue, but in general, many of the colleges have still older teens and people in their young 20s. So the one is the risk probably for schools is low. What we really would like to have is still some plan as this epidemic either sort of slowly flames out for a little while, but is likely to come back in some fashion in the fall. We'd like to have more testing ability and still have social distancing as much as possible. So how to do that? I don't think any school knows how to do that. And then the question is, how can you do any kind of teaching outdoors at all, which would be good. Can you space the students apart in a reasonable distance, that with the windows open or with fans on, or perhaps with more air exchanges? So we may be able to get some technical help from engineers. And then what do you do about sports? The same sort of thing. Again, we have low risk for getting severe disease, even of having recognizable symptoms in many of them, but it's not zero. And a couple of young people, even without underlying diseases. So again, risk tolerance. Can we do anything to separate the kids? Can we have delayed school timings? Can we have smaller classes? Hand washing availability. These are things that are all going into it, but I see still a lot of challenges to make people feel comfortable.
Uh, our friend Samantha asks, because droplets can stay in the air for hours, when our offices reopen, should we wear masks even if we're not in close contact with anyone, just to mitigate that airborne transmission from walking through shared spaces? And there's kind of two pieces of that. Many of us now are living in states where there's a possibility that we could be returning to the offices, or offices are starting the protocols to reopen. Masks, are they going to protect you from those airborne particles, or is that really about you protecting other people?
Well, masks will protect you from some of the airborne particles, even the surgical masks. We know that. If you think about the best way to protect from truly airborne, the aerosols for 2 or 3 hours, that's going to be the N95. And so you would have to sort of describe the situation you're in, your risk tolerance, what the air handling is, and the number of air exchanges, for example, in an office. And are there any kind of physical barriers going on? So if you're certainly a high risk person, maybe you have diabetes and heart disease, and you're back in a group. I would be more inclined for that person to be leaning towards a mask uh, than someone who has no underlying diseases. So all of that has to play in. And remember, we're in uncharted territory. So we're doing our best making common sense without hurting people and making them uncomfortable.
M. Lawton has a good question that I've been wondering about myself, which is I've seen a lot of people walking around with a mask covering their mouth, but under their nose, just sitting right here. Can the virus be transmitted, infect others equally by the nose or the mouth? Do you need to cover both, or is it okay just to cover your mouth?
Well, I think you need to cover both. We don't have any data really to say how many droplets and what size they are from the nose. But there are people who you could see snorting on the road, particularly if you're protesting. That's a possibility. I think they expose themselves to one more mucous membrane to pick up a virus. And to me, I don't understand that. If you're going to put it on your mouth, I understand it's a little more uncomfortable to put it over your nose. But I think the wisdom would say that masks work, and we don't know what proportion of infections were by the eye, the nose, or transmitted into the mouth and lungs directly. So that would be my basic sort of thinking as I try to put that in perspective.
Okay, we are a little past the top of the hour, so I'm going to close with two questions. Thank you for being so generous with your time. One is, this is a tough question to ask, but I saw Tony Fauci just the other day on a quick video thing. This question was put to him, so I'll put it to you. Are you feeling more optimistic now than you were 4 weeks ago, 6 weeks ago? And related to that, how comfortable are you as we see all these vaccines now going into, in many cases, about to go into phase 3 clinical trials? Without knowing an outcome, does that give you cause for optimism as well?
So my optimism is certainly a number of companies are in clinical trials for drugs besides Remdesivir. And secondly, as I mentioned, a number of companies are in phase 2, at least, for a vaccine. And that some of the vaccine might be available by late December, and including even millions of doses that are. So that should give some cause for optimism. That has to be balanced a lot with the fact that we're opening up our society and we'll feel good in the summer because many people will be outside, and that may modulate in a favorable way the number of cases. What gives me a little concern more would be the fall. In the fall, we would expect as countries around the world open up, we'd have importation of cases from around the world. We're going to be inside more often. We're going to have a group of people that have fatigue for hunkering down going on. We'll have the second wave on top of COVID of influenza. So this is the year to get the flu vaccine. I keep telling people. I worry that on top of that wave of influenza, we may see spotty outbreaks of childhood infections like measles, because the measles vaccines take in children that's dropped by 50 to 80% in some age groups. And that means we're really going to be exposed to these. And moms should get out there and immunize their kids because measles is serious. It's not only life-threatening, it's sight-threatening, and it's a pretty horrible disease. And then the last thing to mention, which you have to be cautious about, is the cyber terror targeting hospitals and healthcare systems that appears from a Forbes article recently to be on the increase. So there are a lot of things that we would not do well if they all sort of collided at the same time. So I have a balance in favor of optimism, but optimism with the persistence to try to control this, as I've said earlier.
Gotcha. I'll close with the question from Mira. Our friend asks, is there any helpful reason to get an antibody test right now? We know you talked about this before, but maybe just repeat this. Does it really tell us anything, whether it's negative or positive? So thoughts on antibody tests as more and more of those are becoming available on the market.
It's a great question. And if you have a really good test that gets out of the starting blocks and you know that has a real sensitivity and specificity of 90% or more, Probably it predicts accurately. The problem is that in a recent article in the New England Journal, people question whether the tests are really that good. And if you're really at only 70%, which these investigators suggest may be the real sensitivity and specificity, then in fact, you'll have a loss of false negatives, maybe 25% or more. And a false negative will probably not help you because you may assume that you're immune and then get exposed to people and get surprised when you come down with illness. So we're still trying to figure out, even with that article last week in the New England Journal, how good are our tests today? The manufacturers say they're very high, but what they do is actually essentially spike a swab with RNA and say that of 100 spike swabs, we picked up 90 to 95. What the investigators are saying, well, what you really need is a jury of experts to say that you have 100 patients who really have COVID, and then look in that population. Well, I don't know that that's ever been done with a vaccine, with a infection before. So this is new turf and new argument. And I just wanted to show you what we know and what we don't know. The worry is false negatives.
Copy that. Well, sir, before we let you go, last question would be, and I should have asked you this the last several sessions, is there a question you wish someone had asked, whether it was me or somebody else, that we didn't get to? Something you wish people knew, but we didn't get to in the questions, the question you wished you were asked?
No, I think the question about antibodies was the one that I was thinking about we might go to next. But I think people have covered a lot of the basic issues. There may be more questions out there about the crowds and protests and so forth. But I think what I've tried to do is cover, again, what we know from data in the literature about crowds and transmission of viruses. So I think we've covered pretty much what I would want to cover in this.
Well, thank you very, very much, sir. Do
Pleasure.
appreciate it. To everybody who's been with us, thank you for making the time. We're glad to know you're all healthy and well. Dr. Wenzel, if you don't mind, I'm going to ask you, if you wouldn't mind, maybe we could give you a little bit more time this time, just to sort of space it out, because you've been so generous and kind. But would you be willing to come back? Tristan and I can follow up with you. Have you come
No,
back?
that'd be great. I think you're right about the spacing of time. Let's see what happens. We may learn more about vaccines and drugs and more about transmission. So that'd be terrific. And I think it's the appropriate spacing time.
All right. Well, then thank you very, very much, sir. We'll have everybody back again, probably not in 2 weeks, maybe a little bit further out, 3 or 4 weeks, but Dr. Wenzel will be back. To all of you, be safe, be well. Dr. Wenzel, you have all of our thanks. You have done a tremendous kindness to all of us.
It's been a pleasure working with you. Thanks, Sean.
Very, very grateful. Thank you, sir.
Take care.